The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good morning, TMD warriors, or good afternoon, wherever you are and whenever you are watching this. We are gathered here today for the next episode of TMD Demystified, and I am Tony Urbanic. Today, I have a very interesting topic to talk about, which is rather extensive and having to do with treating your patients, whether they be TMD patients or routine, quote, whatever routine is, dental patients or medical patients, or it even applies to dealing with anybody. But in this realm, we are talking about the profession of dentistry as it applies to the treatment of TMD. Title for today's episode is The Angry Patient and TMD. The Angry Patient and TMD. And like most of my episodes, they are triggered by actual experience, recent experience, that brings me to the conclusion that I need to talk about this particular thing to help other doctors who deal with it on a daily basis. Whether or not, in this case, whether or not you're treating TMD, but it specifically applies to TMD. Yesterday, I saw a patient, a young man, 31 years old, who sat in my consultation room with his wife. And when I walked in the room, I always introduced myself, and then I kind of looked the patient over and looked the x-ray over to see several things. Mainly, is there any damage, x-ray damage, that can be seen on the Panorex x-ray. But as I walked in the room, I could feel an emotion, and I couldn't tell where it was coming from. It was coming from the wife, and I looked at her, and now she actually had kind of a smile on her face. It wasn't a smirk, it was a smile, like, I'm happy to be here. But the young man sitting in the chair, to me, looked very angry. Now, this is not unusual. This is not a one-off. I have seen it many, many, many times, and this is why we're going to discuss it. We're going to discuss dealing with the different tones that people come in with that make your life as a doctor more difficult, and in some cases make it extremely difficult, or can even, if you don't recognize it, know how to deal with it, even ruin your day. So this young man, I'll tell the story. This young man had what started out to be a 6-month history of extreme pain in and around the temporomandibular joint. It was just 6 months that he told me his initial symptoms were excruciating pain, and it was around the right side, as I recall. As I sat there and listened, and I looked at the x-ray, and the x-ray showed me that there were some bony changes within the temporomandibular joint, not the worst I've seen, but there were subchondral cysts there, meaning, if you're not familiar enough with this, subchondral cysts are literally cystic cavities within the condyle of the temporomandibular joint, which converts to chronic inflammation within the temporomandibular joint over a long period of time. So subchondral cysts indicate long-term inflammatory changes within the temporomandibular joint. The inside of the joint is breaking down, is what it really means. Cystic cavities are forming, which eventually break down and give you eventual changes in the contour of the joint, with the ultimate being the hockey stick, which all the surgeons know all about. When it gets to the hockey stick appearance, that means years and years and years of damage. But to stay on point, this young man, as I talked to him, was very reticent, but I could pick up his anger. Now, because of my experience, that did not frighten me at all. And I hope that by the time we finish this episode, you will have a lot more working knowledge of how to deal with this kind of thing. But you, as a dentist, specialist in dentistry or general dentist, have had experience with what I am speaking. Excuse me for that. And it is not unusual. So as the story goes out, I went through listening to his history, and he was certain that this was just a local event, but it was excruciating pain, but only for the past 6 months. So I went into going down the symptom list, because he had his symptoms located here, and that was his problem. But I was interested, let's just say, not skeptical. I was interested in what the total story was. So going down the history of symptoms, he listed off, when I went down through, do you have or have you ever had frequent or recurring headaches, earaches, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And he checked on that differential diagnosis of symptoms, all of them. Yes, 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 yes. And then I started, as I went through it, well, when was the first time you had these symptoms? And his history was typical of people who come in, and his headaches and jaw pain started 15 years ago, when he was approximately 15. He claimed he did not clench or grind his teeth. And then his wife chimed in immediately that, well, he makes a tremendous amount of noise with his teeth at night. And then later on in examination, I examined him and found that he had sublingual tori, which verifies clenching and grinding bruxism over a long period of time. You can't have tori in the mandible or the maxilla without a long history of bruxism. That clarifies that this patient is a bruxer. My point giving this history is getting back to his tone level. It didn't take me long for him to share his experience trying to treat all of these other symptoms since age 15, starting mainly with jaw pain and neck pain. And oh, by the way, this is an interesting case. As he was sitting there, it didn't take me, when I walked in the room, I noted his anger, but I also noted his significant class 3 position of his mandible. It was way out there, which will come into play as I describe this in a minute. I don't think he was angry because he had a class 3 mandible. He had a prognathic mandible, an obvious orthognathic case, obvious. But as I sat there and I garnered his symptoms from him, and I asked him how long this was going on, and I finished my examination to sit down and discuss my findings and what my recommendations were. It was obvious that he was very angry because he had seen many, many doctors over the past 15 years to try to help him with one or more of these symptoms. And when I pressed him for how many doctors, he even got angry. You could see he sat up and like he exhibited the anger just a little bit stronger. And his answer was, when I finally got it out of him, because he said, I don't. I said, how many? At least 20 doctors. And then he began to open up. Until then, he was reticent. He was incommunicative. All I could see was his anger. He did answer yes or no when I questioned him on the symptoms. My point being that this patient was angry because he had been abused by the system, our system. And this is not unusual at all. I see it all the time. That's why I just take it as just another day's work, seeing it, recognizing it, and dealing with these patients. Well, first of all, how do you deal with it? Well, first, you don't let it upset you. Don't let their anger rub off on you. See it for what it is. Sit back and relax, because once you see it and you know what it is, and I'll give you a key on how to best handle it a little later on in this episode, in this discussion, something you can practice that works. But dealing with the angry patient in most cases is the doctor's dilemma, and it's the last thing he wants to deal with in a day of work. In this case, because I knew what it was and I could handle it nicely, he went on to accept treatment, and by the time he left the room, his anger had totally settled down. And by the way, I discussed this at the end of the day on our daily muster, which is always very brief, no longer than 5 or 10 minutes max, sometimes not that long, with my staff. And yesterday afternoon, I brought to their attention this patient, and each of them acknowledged that their contact with the patient, they had noted his anger starting at the front desk. And as he went through our system here, brought back to the consultation room by my assistant, she noted that he appeared very angry. And then after the consultation, my financial manager, who had to speak money with the patient and his wife regarding treatment, chimed in during the discussion with my staff that by the time she got to see him, he didn't appear angry at all. And so we had settled him down by discussing the facts of temporomandibular joint, giving him hope. You know, there's always skepticism involved. I don't deny that I'm sure that he was very skeptical after seeing 20 doctors and getting nowhere and having all kinds of different recommendations for the treatment of his symptoms, that he had some degree of skepticism. But, you know, as I went through the symptoms and described for him how inflammation within the temporomandibular joint creates all these symptoms directly, and it's not rocket science, patients can understand it, and how the specific device, the Urbanic device, unloads the temporomandibular joint like a set of crutches unloads a bad knee and decreases inflammation in the knee, and the device decreases the inflammation in the temporomandibular joint. He began to understand, and his anger started to decrease. Point one, communication is the answer to anger. Now, it's very hard to communicate with an angry person. In fact, that's the problem. You have a patient come in and they're really angry because their $2,000 crown that you just put on a week ago popped off, and they chewed on it and it broke. They're very angry. It's hard to communicate with an angry person. That's a fact. But the point is, don't let it throw you. And communication doesn't cost anything. And as long as you don't respond in kind, because the last thing you want to do is respond with that same emotional tone, because that's a point I'm going to bring up in a moment. You know, everyone carries with them an emotional tone at any point in time. You yourself get angry or other tone levels, and it affects not only you, but the people around you. And in so doing can affect the actual circumstances of your entire life. So staying on track, talking about practice, talking about TMD and the angry TMD patient, you're going to see this. And almost exclusively, the angry patients that I have seen in the TMD consultation chair have been angry because they've been abused by our system. And I can't blame them for that. I am frustrated. I am frustrated to see on a daily basis the misdiagnosis and mistreatment and misdirection of symptoms by our medical community, being migraines misdiagnosed, Meniere's disease misdiagnosed, ear infections misdiagnosed constantly as something else when it's actually TMD, inflammation within the temporomandibular joint. Well, we won't talk about dealing with your own frustrations, but the point is you dealing with patients with different tone levels. So let's, Voltaire said, and I've said this earlier, if you are to argue or talk with me, please define your terms. So what is tone? The second definition of tone as a noun, T-O-N-E, tone. And this is right out of the dictionary. The general character or attitude of a place, a piece of writing, situation, or I will add, a person. The general character or attitude of a place, a piece of writing, a situation, or a person is called the tone of the person or place or situation or writing. And tone levels vary on a patient from time to time. I'm certain that this young man did not always, and at every part of his life, act angry. But when he sat in front of a doctor to treat his symptoms that no one else could address and that had been misdiagnosed and mistreated for quite some time, it generated anger. Now, there are other tones that a patient can go through that you will see in your practice, and as it applies to patients sitting there with TMD. The next one that comes to my mind is a patient who are in apathy about the problem. Totally, they're sitting there. How they got there, somebody dragged them in, or somebody referred them in, a friend or a dentist referred them, or even, around here, we have a lot more physicians sending us TMD patients, more physicians almost than dentists, because the physicians are starting to wise up on how to diagnose this and not misdiagnose the symptoms. But patients who have had this problem untreated and unresolved for many, many years, the average patient that we see in this practice, and I mean average, has a history of 20 years of symptoms before they roll in the door here. There are many that are less than 20 years. There are many that are longer than 20 years. But the average is about 20 years. And when they find out that their migraine headaches are not migraines, but coming from inflammation within the temporomandibular joint, they change their tone. It could go up, it could go down. But in this case, we're talking about the apathetic patient. When a patient comes in and it's just sitting there and hardly want to speak, it's hardly to draw out an answer, yes or no, have you had these symptoms? You can tell that at that time with you, they're sitting there in apathy over this problem. Because as everybody knows out there, patients, doctors, physicians, dentists, then when it comes to this problem that the culture calls TMJ, everybody knows nothing works, which is the big stopping barrier about getting the word out that, yes, there is a solution to TMD, a non-surgical solution that is predictable and works very, very well, and high probability of success in the 90s. And the remaining patients, frankly, are patients who just refuse or can't do the protocol, which is to keep it in your mouth long enough according to protocol. So now we talked about two different tone levels of patients. You got the angry patient, you got the apathetic patient. Well, again, the solution to the apathetic patient is not to go into apathy with them, but to communicate with them about their problem on a professional level without being upset. You don't want to let these tones upset you to do less than an ideal job of serving your patient. I mean, that's what we're here to do. We're here to serve people. We have a license. We are lucky to have the education and license that we have to treat patients as professionals, as dentists, as physicians. So, I mean, that's how you need to look at it. And that's one of the take-home messages from this episode. It isn't just about acknowledging and being able to recognize the angry patient. It's about recognizing that your patients sitting in front of you are going to have different tones. Most of your patients, I mean, 80% of your patients are going to have a similar tone level that will not be difficult for you to handle. But there are other tone levels that you have to deal with because they're sitting in your chair. The next one that comes up is the antagonistic person. And, it doesn't take long for you to determine that literally they're pushing your buttons of one way or another. If you have someone who is pushing your buttons on any topic, then obviously be a little cautious. But the person who is antagonistic is on a lower tone, and patients go through these tone levels on their way up to even enthusiasm. Let's take the highest tone level is enthusiasm, and that's the tone level that most of my grandchildren express constantly, except when they go down tone, when they fall and scrape their knee, or one just cut his finger with the knife he wasn't supposed to be using. And, he went into grief and started to cry immediately from enthusiasm down to grief. And kids will do that up and down, and you can see it obviously. It's a good example to speak on. But adults do the same thing, but not quite as fast, And if you'll start to look at the different tones that your patients come in with, it makes your life better. It makes you a happier doctor, because you actually, once you see it, you can't not see it, and you recognize it for what it is, and you're not upset by it. And then you begin to learn how to handle it by communicating with the patient. And here's the tip I was going to talk about and give you, is that you speak to them on just one tone level higher than they are. So the tones that I see frequently going down tone, well, let's do it the other way. Let's talk it up tone. The lowest tone level that we see that I've spoken on already is apathy. And then from there, patients begin to go up tone in their appraisal of the situation or life, which the next is hopelessness. Hopelessness is above apathy. I mean, apathy, they're just sitting there doing nothing. Hopelessness is similar, but just a little notch above apathy. They kind of look the same way sometimes. Then above that is grief. They're really, it's a loss. They have all these pains. They have all these symptoms. They haven't been treated successfully, and they're grieving over it. It's a rather low tone position. Above that is despair. They will come in but they will be able to vocalize it. They'll be able to vocalize that they are in despair. I've tried everything. You're my last hope is one I hear not infrequently. You're my last hope. But at least they're able to talk about it. They're in despair, and you can know they're in despair because they're telling you they're in despair, but that's a higher tone level than apathy, hopelessness, and grief. Above that is fear. You can see that in their eyes sometimes, and if you're a dentist, you see it all the time. People are fearful to sit in your chair. I mean, how many of you who've walked into a room and they won't even sit in the chair because they're so fearful? They're in the patient's chair in the corner or standing up. They're afraid to even sit in your chair. Easy to recognize, okay? So they're in fear. And then above fear is anxiety. They're the ones that are twitching and they're moving their hands. Some are sweating. And then we get actually anger. Above that is anger. It's a rather high tone. It's a rather high tone location. And again, easy to see. I walked in and described this particular patient, which started out the episode. And then above fear is antagonism. And that is the one I was just speaking on. And they will start to antagonize you, maybe indirectly, but they'll say, well, I saw Dr. So-and-so, and he said I shouldn't come to you. Or I saw Dr. So-and-so, and he didn't help me at all, and I bet you can't either. And stuff like that, It's like, I laugh at it because I understand it doesn't bother me anymore, because I understand that everybody has a tone at any particular time. Their tone changes depending on the circumstances of their life. If they have a significant loss, if you have a significant loss in your life, you're going to go to grief. No doubt about it. And if you have a win in your life, if you have a success in your life, you're going to come up tone. And how do you deal with someone at a particular tone level? Well, you deal with them, number one, by keeping the communication in, not letting them frighten you or go down to their level of tone. And you address or attack the problem and address them at a tone slightly above where they are. And that's the best way to communicate with them. So in this case, patient was in anger, and I did a little communication with him in antagonism. I learned that he had a job. Both he and his wife had jobs, and he cleaned pools for a living. It's nothing wrong with cleaning pools. I clean my own pool, but it's a valid service for people in exchange. And as a pool cleaner and a pool person, he can make a good living. So it's certainly not derogatory that he cleans pools, but he was also in anger, and I addressed him in a little antagonism, not about pool cleaning, but about the way he was speaking. And so very light little antagonism nuances to my discussion with him. I confronted the anger. And I just did just a little bit of antagonism and shot back a little bit above anger and left it as antagonism. And as I did this, I could see he was communicating more. He was listening more. He was talking back to me more. And we got back. That's how I got back into, and this is why I started this episode, because it was so obvious to me that this needed to be brought to your attention as a helpful matter for you. That he began coming up tone. And as I said earlier, by the time we went through the whole diagnostic process, and he ended up with my financial manager, she said that he wasn't angry anymore, although she had heard the other employees say that they saw him in anger. So this is a universal problem. This just does not have to do with TMD, but I'm in the TMD business. And if you're watching this, you're either in the TMD business, or you want to be in the TMD business, or you want to learn more about TMD and how to treat it correctly. And that's what these episodes and my purpose is all about, in teaching doctors how to treat TMD successfully. Obviously, there's a clinical part to this. We found out that if you unload the temporomandibular joint using a specific device that we now call the Urbanic device and protocol, the results are extremely successful. But there's more to it in treating these patients. And if you really learn from my experience, is what I'm trying to share with you here, you can go a long way with this, and actually it will be a lot more fun to treat these patients. I've said before, I sat in surgical lounges waiting to get into my next surgery with my medical surgical colleagues for 30 years, longer than that, 40 some years. And it was very common for whoever the doctor was that I was sitting there with, waiting to go in. We'd talk about what we were doing and our experiences. And when they found out that I was going in to treat a TMJ case surgically, this was many years ago, longer than 12 years ago is when I quit doing surgery for the temporomandibular joint, they would say something like, "Tony, why do you take on these TMD patients? You know they're all crazy." The physicians thought that, they said that. They didn't mind being a little antagonistic to me. That's okay. And my response to them, because I had learned enough by that time, is that these patients aren't crazy. They're crazy with pain, which brings back to their tone level. Pain will bring you down tone, just pain itself, obviously. Obviously, my grandchildren have proved that. When it hurts, they go down tone into grief and the tears. Of course, we know they're okay. They're okay. They're just at a lower tone. And as soon as, you kiss the boo-boo or put on a Band-Aid, or in this case, take them to the convenient care clinic and put in a few stitches and give them an ice cream, then all of a sudden they're in enthusiasm again. I think I made my point. I hope I made my point. After this, I'd just be repeating myself. I think this is one of those episodes, it would lend itself to reviewing it from time to time. It takes practice, it takes a little knowledge, but it applies certainly not, it goes way, way, way beyond treating TMD patients. But because I saw a patient yesterday who was in obvious anger, and that is a tone, I thought this is a good time. This stimulated me to spend a little time with you, discussing the problem, discussing the solution, discussing that you're not alone by seeing these kinds of things, seeing it for what it is. Once you see it, you cannot see it. And once you know what to do with it, you really enjoy doing it, because you have control. You have control of the situation. When the patient's sitting there in a lower tone and you don't know what to do, you've lost control. They're in control. And as a doctor, in the doctor-patient relationship, frankly, it just speaks for itself. The doctor needs to remain in control, or things go off the rail rather rapidly. And my God, that's a whole other episode. But enough said for today. If you are interested in learning more about TMD clinically, specifically, how it applies to all the patients, how patients and our system actually needs to be improved significantly, you can learn about the Urbanic device and protocol. You can look a lot of material on our website, new website, www.urbanictmj.com. I can be raised on the internet at my email address, tony@tmjservices.net. Our Director of Education and Marketing, Dr. Naomi Williams, would be happy to discuss and give you any additional information you'd like to learn about our device, our company, and what we do, and to make you as successful as our practices and other practices are who use our device. That would be Naomi@tmjservices.net. Until the next time, which will be in exactly 1 week on a Tuesday morning, I look forward to this next interlude and episode, but have a good week. And I definitely enjoyed speaking with you on this topic. I'm Tony Urbanic, and this is TMD Demystified.